It gives me great honor and privilege to stand in front of you and engage in the most important topic of our life, particularly as this generation of health leaders in 2019. It also comes at a time where the United Nations also had this type of discussion and engagement in the past few days or so. And I had prepared some slides, but I just thought sometimes when you come with slides, you give an impression that somebody has prepared the things for you. You don't really understand what you are actually about to talk about. And secondly, I thought the slides will make it too much artificial in terms of our engagement. But sometimes it's not about what you have read or what you have researched and what you have been told. But sometimes it's what you are told. In the era of the post-truth era, a number of things are post the truth. So there are other alternative facts that are put across. And you know, one of the leaders of the world who believes in the alternative facts and the alternative truth also doesn't really believe that universal health coverage is something that we need to support, and it's the way to go for his country. For whatever reason, I think you would know him better. But it's an ideological matter, or sometimes it's just being mentally not okay. I'm going to speak to you firstly as an activist and also as a clinician, because I can't divorce myself from that, as a clinician and as a medical practitioner. So I'm going to speak to you in those contexts and those platforms. And I think what is important is that I want to give you a firm background on, in essence, where I come from in terms of what I believe in or what I would say about the universal health coverage today. So it's not something that I've researched, read around on Google and so on. It's something that I know. So I'm going to speak to you as a person who has went through training as a medical student. And as a medical student, I had an opportunity to work in different environments and provinces. Most of you would know that Medunsa is attached to George Mokari, which was Harangua at the time. And I also did part of my obstetrics or maternity rotation block in third year at Natal Spread in Katlehong, Thokoza. I also did my other rotation, elective rotation as a medical student at Bara when I was doing 5th year and 4th year. And we also had an opportunity as medical students in Medunsa to work in the rural parts of the province, of our country, in Chilidzini, in the Mvembe region, in Limpopo. And we also worked in Polokwane and Mankweng complex, and Nkowankowa. So as a medical student, at least I had a basis of what the health system is all about, both from the perspective of being in a town, in a city, in a township, in Soweto, in Thokoza, Katlehong, and also from a rural perspective. I will also talk to you with my experience as an intern and ComServe doctor in Charlotte Maxeke, Johannesburg Academic Hospital. And also as a registrar in training in obstetrics, where I also rotated in Charlotte Maxeke, Chris Hani, and Rahima Musa. And post qualification and post training, I worked as a MO at Pulusong, and I also worked as an MO at Kresaripanwa, Baragwanath, and I worked at Telemogerane as a head of unit. So I'm giving you this so that you understand that what I'm going to talk about, it's not what I've actually read or researched or what I heard people say, but it's something that I appreciate very well. And I think all of us would agree sitting here that access in Gauteng is not a problem. You would know that our borders are open. So somebody from Harare can just access Charlotte Maxeke without any problems. Somebody from Mpumalanga can access Chris Aripana Kwanath or Steve Biko without problems. And so on and so on. So access, I think, in a broader scheme of things, if you want to be narrow, like other people would like to do, and say that universal health coverage is aimed to increase access and not for those who have previously been disadvantaged and not have access. But in Gauteng, I think we've got a different view and a different picture on that matter. But what we'll all agree is that we agree that our thinking and our understanding of universal health coverage, NHI in particular, is about the quality of healthcare. So when we talk about the quality of healthcare, what do we mean? There are a lot of descriptions and views. Other people say when you postpone operations also affects quality of care. But I also think that we need to be able to address those issues. So for me, as an activist, it's important that we improve the quality of care. We need to deal with issues about staff morale in our department, because I think generally all of us would understand that our staff members are burnt out, fatigued, and there is a chronic shortage. Okay, if I say chronic, it gives an acute shortage of staff in all facilities, which leads to fatigue and which leads to burnout. We also don't equip our hospitals and facilities quite well. I think most of you were part of the engagement about the MRI, the comments I've made on the MRI. But the basics is that if you have an institution that doesn't have an X-ray, you can't think about an MRI as a first line. And you cannot say the absence of an MRI then presents a crisis and a collapse of a system, like many people have given us that view. But I think it's important to mention that MRI is an essential diagnostic tool, but it's not really a first line in every way or in any of our imagination. So I'm addressing you on the issues of quality. So we need to talk about quality. And I think from the topic is that we need to talk about how Gauteng itself will structure itself and move forward in terms of how to improve quality. I'd undertake the issue of the staff morale as one priority that we need to deal with. Most of you are the ones that mobilize the community, mobilize views about our staff members, demonize our nurses. Of course, when they do wrong, they need to account, and we need to be transparent. But most of the time, we use the alternative truth type of approach. We believe what we read, even if it's stuff that sounds like it comes from the Daily Sun, but we believe it. The patient experience is a big problem in Gauteng. They are interlinked. So when you interact with a fatigued, bent out staff, of course your experience won't be very well. You will get out and think, this facility, it's supposed to be a place where I'm going to be cured, but now it's where I'm tormented and tortured. Other people make comments that our hospitals are mortuaries. I don't know. But it's one of the things that comes from you, professionals, entrepreneurs, people who've got access to medical aids. They normally make those comments about our facilities, and that's why they think that universal health coverage is not going to happen now, because we have those problems in the public health system. But I think all of you would know the facts about Gauteng, that we've got 15.8 million people that we're dealing with. and we've got 26 million visitations in our facilities. Not patients, but visitations per annum. And if all of us then take those numbers and we say that the system has collapsed, I don't know. Because people still get cured, people still get operations, and they still get seen by our specialists, they're seen by our nurses throughout. Our annual growth is around 250,000. They say the bigger provinces that contributes to this growth of Gauteng. It's not that our fertility rate is quite low, it's 1.8 in Gauteng, but we continue growing. But it's people from Limpopo who are here. You heard us when we introduced the leadership of PPF. And also from Eastern Cape. So they contribute to the 2.5, to the 250 per annum growth. And our fertility rate, in Gauteng they say we are too busy to make babies. We don't make enough babies. So it's dangerous somehow if you look at the population growth that we are not even replacing those who are dying in Gauteng. But the population is growing and it's a moving target. So I'm saying these things because I'm basing everything that we're going to talk about quality and how the National Health Insurance is going to help us to improve the quality. And of course, people say, I think, about the pilots projects, that NHI pilot projects. Okay, the number is put that they spend 3 billion. I'm not sure how much is spent, but economists will tell us. They are quite accurate with those numbers. I am not one. But I think there are important lessons that comes out from the pilots themselves about the usage of the community health workers, that they are quite important in terms of the primary health care, how we strengthen our primary health care, how we decongest our facilities. The other part that we have learned from the pilots is the central chronic medical dispensing system, which utilizes retail pharmacy and other pharmacies to go for those who are coming to collect chronic medicine, to not go to the clinics or hospitals to get their medicine. So if you can perfect that system and distribute it and roll it out, there won't be a congestion in our facilities. Okay, the issue of contracting of practitioners, those are good lessons that we have learned from it, what needs to be done and what needs to be perfected in that system. And it must be now beyond practitioners. It might involve specialists, you know, it might also involve nurses when it's possible, because the possibilities are endless. But we just need to perfect how we contract and utilize practitioners who are in the private practice. There's also the patient registration system that has started. It's almost at 80% now, which is the one that we're utilizing. And most of you wouldn't be registered sitting here because you have not visited any government facility in recent times. But those who have been, they've been registered, their names are there, and they've been there. So there are a lot of lessons that we've gained, and there are other good ones, there are other bad ones. But there are things that are only going to reflect on the good ones. And I think there will be those who will concentrate on the negatives. Because, you know, there are pessimists that go around, you know. They say pessimists, they've got a problem for every solution. You know, so when we discuss the bill now, because the bill, it's a structured thing, it has got fun, people want to discuss the powers of the minister, that's fine. They want to discuss the role of the province, that's fine. I think the public process will engage on it, but ultimately, as the ministerial government, we need to be able to run both the health, public and private. You know, we had a discussion here some weeks ago that gave us an idea that, you know, in actual fact, private can't do as they like, because we actually give them the license to work. We give them the license to open the hospitals. So it means we can determine how they cost and what they charge, and where they put up their facility. And I don't think there's a worry about it. It's not constitutionally illegal. Ne? We can determine it because we are government. Okay, that's fine. But I think we also want to say that the bill itself is just establishing a fund. And what it will do, of course, it will open up a lot of transformational questions that we need to talk about. Let me talk about the powers of the province, just for a bit. Historically, provinces, the ANC didn't believe in existence of provinces because we're trying to run away from Bantustans. But because of the discussions and the nature of how South Africa came about, this future that we're talking about brought about that we then have provinces. And then, of course, they then had to sit around after 1994 because there was no plan. There was no idea how we're going to structure and consolidate the health system in the country. There were Bantustan departments that we had to integrate. There were provincial authorities, TPH. Those who are old enough will know TPH. I think Brian will know them. But he will tell us that when they said in 1994 they didn't have anything as a blueprint to say this is how we're going to evolve the health system. But they said, they discussed, they came about with what we're having now. Okay, now it's a bit complex because it has grown a bit. So everything else was always on the district platform. So we need to think about it, whether the provinces, are they going to be service providers? Now the bill says that they will run EMS and so on, and the powers will be given by the minister. But I think it's a discussion that we need to have as a country. It's a discussion that we need to have, and people must give us enough reasons or not to have them. But again, coupled to it, that the delivery model of the 6th administration is based on the district. So it should be integrated from the district point of view. What we have discovered is that local government goes and do their own planning. They go and ask the community what do they need. And then the community says, no, we need a hospital, but we know that municipalities can't build hospitals. So it becomes just a deferred demand. But now with the integrated delivery model, it becomes an integration that we all know what the school needed, a dam, and so on and so on. So the issue of provinces is an issue that we need to debate and discuss. I see Prof. Buch is also here, so he was part of the group that were in the discussion after 1994 on the role of provinces. So yes, I think people who are somehow anti-universal health coverage and anti-NHI, they will talk about the powers of provinces in that manner. So let me proceed by saying on the bill is a draft bill. It needs to be engaged. There will be matters that we are not going to compromise. We are going to engage on the ideological basis. The issue of the role of medical aids, we have to debate it on ideological basis. I like what the Secretary General of the United Nations said about the support or anything about universal health coverage, that it's a political choice. So we need to engage it in that matter. That what will be the role of medical aids? And going forward, there's the concept of supplementarity and complementarity. But I think in essence, all of us who've got medical aids here know that post-June, your medical aids have actually run out. So whatever you say about medical aids and everything, the fact of the matter is that you pay out of your pocket every year. And it's a substantial amount of money you pay out of pocket. But have you imagined that do we cut down the CEO's salary of people who run medical aids because you can't get cover because your medical aid has run out? You don't get assistance, but the salary goes out and the shareholders get bonuses and everything. I think it was in the papers or something that the CEO got 135 or 125 million last year of discovery. It's a figure like that. You can Google it, you will see it. I think he's one of the people who were part of the first discussion of health universal coverage, Dr. Brumbeck. So medical aids, they've got their own shortfalls. That even if you pay so much, you still have to pay out of your pocket. And even if you argue for more power and more, they even regulate us. You know, those who are practitioners, they know how highly regulated the system is. They tell you who to go and see. They tell you what you can't have. You can't decide when you're on kick care. You can't decide to have a Caesar, even if you've got 2 Caesars, you know. So there are things that we need to talk about, which are negatives. And I think medical aids, they have a role somewhere, but in a bigger scheme of things, I think they don't really meet the requirements. A lot of what we pay to medical aids end up as bonuses for executives and goes to the shareholders and doesn't cover and go to health, even for the members themselves. You know, if you do have a medical aid and it covers you completely, you've never had a problem, you are a lucky one. Also, the issue of the private sector, the role of the private sector. Most of people who argue, they say, no, the private sector will be affected. Currently, we all know that it's underutilized, the private sector. The bed utilization rate is less than 60% in all facilities. So there are other hospitals that have theaters that have never worked for the whole year. So they also talk about quality in private healthcare. They say it's quality. I don't know, but you will tell me. But I worked also, I had a fling with private sector. I had a fling with private sector, so I know that when you're required to do a Caesar, you need to get an anesthetist. You need to ask for theater, and if you don't have anesthetist, you'll struggle to do. Sometimes you don't see your patient for 2 days. It's seen by nurses. When you've got problems, sometimes the ego says that you can't call anyone for help. And yeah, that's quality. I think the good thing about private sector, it's a bread and breakfast type of situation, which is quite quality. It's 5-star. You know, you've got a TV in your own stretcher, and you're able to choose your meals nicely, which is something that we must learn as a public sector, because if we can't do that, it means people will oppose the universal health coverage for life. But the market inquiry will actually reveal the facts, you know, of over-servicing. It will give us the facts about the information asymmetry. It will also question the ethics behind it, you know, the pervasive ethic dilemmas that happen. But it also talks and opens up other possibilities for medical practitioners in terms of grouping themselves into group practices, multidisciplinary group practices, and so on and so on. But one thing for sure is that the market inquiry in the health sector, in the private health sector, it won't give us the same thing about groupings. Because in other markets, they talk about you decentralizing and making sure that you spread around. But in the health sector, it speaks about you grouping together. So there are those things that we need to reflect on. And I'm going to address in the last 5 minutes on the concerns. I've spoken about the basic pack of the bill on how the universal health coverage is going to be. Of course, we are talking about primary health care. We need to re-engineer our system. We need to concentrate on that fact. The community health workers are going to be our priority. We're going to formalize their functioning in the health system in Gauteng. We have integrated 8,000. We're going to integrate 12,000 of them, taking over those who are in the municipality and making them a good cohort of system that will work. We're going to roll out properly the chronic medicine dispensing system. And now the other issue is the issue of single payer and multiple payer system, which is also a political matter. It's a political matter because when you talk about multi-payer system versus single payer, most people then talk about corruption. So they give us an impression that, yes, we can't do anything else until we completely eradicate corruption. So let's not discuss universal health coverage because we're afraid it might end up being like ESCOM and. And the other concern about it is that, doctors will go, they will emigrate. And I know that most of us who have been in the field and being activists, that threat has been there, It's not only about government and officials who are corrupt, so it means there are entrepreneurs who elicit some form of behavior in our system. But I think it's a societal matter that we need to deal with, all of us united. And I think there are people who are experts in governance. There are people who are experts in governance who can develop proper frameworks for us, checks and balances to make sure that we don't have the same, particularly for a public entity like the fund would be, which is a 3A, not a similar public entity like ESCOM. Then there are issues about the issues of hospital groups, what will happen. But you see, my worry about the discussion about this is that because it's a political choice, it means we must make a decision for the benefit of the majority. Yes, we'll protect the interest of everyone else, but our primary focus is the majority, those who don't get the quality of healthcare that they need. In terms of patient experience, in terms of waiting times, in terms of everything. So I wouldn't speak on behalf of the private. Unfortunately, I wouldn't do that. The opportunities that are there with the discussion, most people don't want to discuss the opportunities. They are there, there are many. Most of you, their first point of call for consultation is African traditional medicine practitioners, Sangoma. So you go there, but now in a bigger scheme of things, they're not integrated. So the NHI or universal health coverage gives us an opportunity to have a frank discussion about how we integrate them and give them. And the second opportunity is that for private practice, is that it gives them an evergreen type of approach. They don't run out of patients after winter. Operations don't stop after winter. So they continue throughout the year because if you are contracted to NHI, then it gives you the opportunity to see patients throughout the year. And currently now, I know some of my colleagues, they are waiting for January so that medical aids can be reloaded again, and then they start. So it gives them a good opportunity that if they're contracted, they will get enough patients. It's going to be a numbers game. But the other things that it gives us an opportunity to purchase services that ordinarily people will delay from not getting. Point in case, which I'm almost killed for, it's an MRI situation. You can purchase it, but it will purchase it at our cost. Medical aids do it, they negotiate. So they purchase services on behalf of their members at cost, but we know it's not for the benefit of the member, it's the benefit to increase their profits. So we can also do the same on purchasing the services. We are going to regulate that, the costing of the public health sector. We are going to purchase services for oncology when we don't have enough. Currently, we are in a process of commissioning 2 machines, radiation machines in both Steve Biko and Charlotte Maxeke, which will bring down the backlog. But we are hoping that before they get commissioned in November, would have purchased and reduced the backlog tremendously. And that's quality for our people. There's also the issue of mental health, which is a big problem. We have to contract because we don't have enough beds. Currently, average one casualty has to admit like 12 patients, and there's a 72-hour observation before you decide. Those who have worked in casualty, they will know that a psychiatrist will always say, no, exclude general medical condition first, before we can then say simply, this is a schizophrenic patient. So that on its own, you have to wait in casualty. And most of our casualties have not built in that way. Some of them are old. The one in Mamelodi is one case in point. The one in Edenvale is structured in a very funny way. It also can have holding then in Helen Joseph. So mental health, it means we have to go out and purchase space for our patients, particularly those who need down referrals so that the acute ones get admitted properly in our wards. And that's for us, there's an issue that we have to deal with in terms of quality. There's a big issue on transgender surgery. Most of you would know that there's a 25-year backlog on transgender surgery. So this discussion on NHI, it's not really a discussion that just focuses on what we want, but it also opens up a lot of discussions to give other opportunities that are there. So in short, I know I didn't present the bill. I'm not here to present the bill. We're here to discuss the politics about the national health insurance, the universal health coverage. The high-level discussion happened in the United Nations. We all know who rejected the whole idea of universal health coverage, those who believe in the alternative truth, who believe that termination of pregnancy shouldn't be a right. Women shouldn't decide on their body, on what should happen. And yeah, but they somehow ideologically, they always align themselves, those who, it was not just like a mistake that even Israel followed suit, USA followed suit. So, but all the other progressive, Latin America, Africa, and others supported the whole thing. So the bill is there. People will have an opportunity to make comments. I've told you the things that I don't think we have to negotiate, that things that are going to make us fight ideologically, single payer versus multi-payer, the issue of the powers of government. And I think necessarily if you don't want to have that discussion, it means you must enter into a situation where you maybe advocate for government change, so that you don't have to deal with a government that wants to control and gets the pooling system in together. You want to have a government that will support private sector over and above the majority who don't get the quality. Just last stats about what were happening. We spend 8.3, I think it's almost 8% of our GDP on health in South Africa, but our outcomes and quality are very low. And in that 400 billion that we spend in healthcare, both private and public, 16% is, they take the half. And that half, that 200 billion that they take up, doesn't necessarily go to healthcare. We all agree. It goes to shareholders, it goes to profits, it goes to salaries, it goes to marketing, it goes to all sort of things. So when you take the half and share it with the majority, and then people say we can't pull it together because we still have the interest of protecting the private practice, and private, it's something else. But there is opportunity for those who are in private, for private hospitals. The utilization rate of their beds will increase tremendously if they allow and contract to NHI. We'll be able to utilize the bed space, and even theater time. We'll also utilize and contract those who are in private to work in our system. I didn't speak about pharmaceuticals, because pharmaceuticals, any discussion for pharmaceuticals, they can actually end up with a change of government. So I really avoid that discussion. But we know that at some point we have to discuss a state-run pharmaceutical company, or it can even end up somebody getting reshuffled, if you push hard. If you push hard enough for a state pharmaceutical company, you might get reshuffled to say, no, you are not really pushing the idea. So yeah, those are, for me, those are the issues that we need to be very firm on and frank on. We can't have a multi-payer system. It's not okay. It will still open us to a lot of wrongness. Money won't be spent on healthcare. And we wait with abated breath the outcomes of the market health inquiry. Just people for the long and short of it, to discuss the quality of healthcare in private health. And today, as a last comment, I'm leaving now. I'm not sure which private hospital or private practice hospital does HIFU. You know what is HIFU? There is one private hospital. Which one? Well, only Bala, as far as I know. Oh, okay. Thank you. I thank you.